Welcome. This session will address the anatomical and physiological mechanisms involved in the sensation of pain and the natural mechanisms available to control pain and the pharmacological mechanisms that are involved in reducing pain. Keywords that we'll be focusing on will include slow and fast pain, the fibers that are involved in detecting pain and the specific receptors involved, the abnormal features of pain involving hyperalgesia, allodynia, and analgesia, the neurotransmitters and activating substances involved in inducing pain, the anatomical structures involved in carrying pain into the central nervous system, into the brain, as well as the unusual features of pain such as referred pain, phantom limb pain, and the natural pain control systems that we have in our nervous system. Pain is an essential part of survival. It is an alarm system that commands our attention immediately, and it warns of potential or actual tissue damage, whether it be back pain, a stubbed toe, a headache, electric shock, or abdominal pain. It induces activity, and that is we can start to fight, we can run away from it, we can roll down to avoid burning to minimize the amount of damage, or we might take medicine to try to reduce pain or ultimately require surgery to reduce pain. One manifestation of a response to pain is something that happens frequently in this hospital, a half dozen times a day, and that is spinal fusion with instrumentation, in which the spinal cord, in order to reduce pain coming from the spine, there are various fixation procedures to minimize movement of the vertebrae and therefore reduce irritation to various pain fibers. In this particular patient had low back pain and right leg pain. Pain commonly occurs at the lower lumbar or lower cervical spine associated with degenerative changes in the spine at those levels that interferes with function either of fibers of passage, in which case you might have right leg pain due to fibers that are coming up from the leg, traveling through the lower lumbar cord and being irritated at that lower level of the lumbar spine. Or there may be back pain due to damage of tissue right at the back at that lumbar level, in which case there is activation and pain felt at the back itself. So one is the radiculopathy and the other is the localized pain, the low back pain. Low back pain is a very common problem, second leading cause of doctor's visits, a very common reason for surgical procedures, a very common reason for hospital admissions, a major cause of disability even in younger people, and after headache is the most common condition reported by patients that involves pain. Pain has at least two qualities that we should be aware of. A first, a fast pain, and a second pain. Pain is a natural phenomenon. We should feel pain when there is damage to tissue. If you take a hammer and hit the hand instead of hitting a nail, you'll have an immediate sharp pain, and it's abrupt. You know where it's coming from, and then over a long period of time, you'll have a second pain that is much more diffuse and produces a much stronger emotional reaction. Those two types of pain are dependent on somewhat different fibers within the peripheral nerve, and that is the large myelinated fibers are preferentially blocked by putting a pressure cuff on the arm, while the C fibers will continue to conduct. If you do that you'll end up, when you produce that hit with the hammer, eliminating that first fast pain, and yet you'll get the very long-lasting dull, more diffuse pain, and it's particularly unpleasant. If, on the other hand, you apply a local anesthetic, such as xylocaine, to the peripheral nerve, you'll find the unmyelinated C fibers are blocked. The lightly myelinated A delta fibers continue to conduct. You'll feel the fast pain, but not have as much emotional impact of the pain. The noxious insults that we experience activate a variety of different pain receptors, nociceptors. They might be responsive somewhat selectively to temperature, particularly very high temperatures, or very low temperatures, particularly very cold temperatures, or high mechanical stress. They're mechanoreceptors, some that are polymodal, respond to many different types of stimuli, and then some silent in the viscera that essentially never fire except in very rare circumstances when they become activated. Most are free nerve endings. They have very poor characterization at this point, but some of them are capsaicin receptors. They're essentially chemoreceptors. And an example is seen here where capsaicin, a chemical component of the hot red pepper, chili pepper, will activate a channel that allows both sodium and calcium to enter the cell, cause depolarization, and sends its fiber up through the dorsal root ganglion, up through the dorsal root into the dorsal horn. Synapses there. On a secondary cell, the secondary cell crosses across the midline to the other side of the spinal cord, forms the lateral spinothalamic tract, goes up to the brain, and is perceived as hot and painful. Nociceptors, particularly thermally sensitive nociceptors, do not respond at low temperatures, but only at very high temperatures, and then they fire like crazy. Whereas a typical non-nociceptor thermoreceptor that gives indication of temperature over the entire range starts to fire a little bit at a low intensity and gradually fires more and will saturate very early before getting up to the levels of tissue damage. So the nociceptor is giving us very, very strong information only at high intensity stimulations, and it simply takes off. It indicates destruction to tissue. The phenomenon of sensitization and hyperalgesia is demonstrated here, and that is if you heat tissue up, initially you might see no response of a nociceptor for a period of time. If you do that repetitively, separated by a few minutes, you might find over time that now the nociceptor starts to respond, and as you continue to stimulate, separated by time, you find stronger and stronger responses. This is an increased response to a stimulus that initially gave no response at all. And that's a very substantial sensitization, and it results in a very strong emotional response. And it's due to lowering of the threshold of the polymodal nociceptors. The acute pain followed by a stimulus may be followed by a very chronic pain that long and lasts that initial stimulus. And it may include the feature of hyperalgesia, an increased response to a stimulus that's normally painful, or may also result in allodynia, pain resulting from a stimulus that normally doesn't produce pain at all. For instance, rubbing your hand over your skin normally doesn't produce any pain. But if there's been sunburn, you'll find that the very same stimulus now produces a remarkable pain, and that would be allodynia. Analgesia is just the opposite. It's an absence of pain in response to stimulus that's normally painful. And that's usually due to damage to some part of the pain pathway, peripherally or centrally, or due to some pharmacological agents, something that suppresses pain perception. Hyperalgesia has both peripheral and central origins. That is right at the periphery where the receptor is, and that is upon repeated application of those noxious stimuli, whether it's temperature or pressure, nearby nociceptors that were previously unresponsive to stimulation become much more responsive dramatically, called sensitization. And that sensitization is due to release of a variety of chemicals by damaged cells and surrounding tissue, including bradykinin, histamine, prostaglandins, leukotrienes, as well as acetylcholine, serotonin, and substance P. These all either decrease the threshold for activation either by directly activating them or simply shifting the threshold for activation. The hyperexcitability in the central nervous system is associated with release of glutamate. And when neurons fire repeatedly, they might release glutamate. If they release it in large amounts, it tends to activate NMDA receptors. NMDA, a subtype of glutamate receptors. And this produces a long-term change in the postsynaptic cells, similar to the changes seen in synaptic transmission involved in the hippocampus and other brain regions, involved in long-term potentiation, a model of learning and memory, also known as LTP. That sensitization may contribute to mediated pain in the absence even of a peripheral stimulus, and we see that in phantom limb pain, where a limb has been removed, and yet there's sensation of that limb that might be painful, and it's clearly due to a change in excitability either in the spinal cord or higher structures that have been repeatedly bombarded by activation initially from the peripheral nervous system. The overall pathway for pain perception can be seen here with the peripheral sensory receptor. It's peripheral fiber coming into the spinal cord, going up to the spinal thalamic tract, and eventually up to the cortex. Those changes that we talked about at periphery are due to a variety of substances released around the peripheral terminal receptor. And you see some of those agents that are either activating the peripheral nerve or that are getting input from the peripheral nerve. That is, there are a variety of materials released from the peripheral nerve that change the milieu around the peripheral nerve. And many of these are lumped together in what's referred to as the inflammatory soup. It's a sterile inflammation, even with no infection here. Many of these agents of inflammation can be seen. More centrally, you see release by a primary afferent into the central nervous system of glutamate, which may activate AMPA receptors as well as NMDA receptors. And the combination of activating all of those leads to an increase in the excitability of the postsynaptic cell. And if this cell is carrying information about pain, it may result in chronic pain or in some cases phantom limb pain. Some of those activities are seen a little bit more clearly in this setting, and where we have damage to the tissue, and as a result we have the production of bradykinin, serotonin, prostaglandins, and potassium from the cells that are damaged. They activate or directly depolarize the nociceptor. That information is sent to the central nervous system, but it's also sent to branches of this peripheral receptor, which send out, in an unusual setting, send out substance P as well as calcitonin G-related proteins, CGRP, that activate mast cells. Mast cells release histamine, which enhance the activation of the peripheral nerve fiber, pain fiber. Other action of this substance P and CGRP is to change the permeability of blood vessels, so you have new blood coming into the area, you have relaxation there, you have additional blood coming into the area, extravasation of serum, and swelling in the area, and redness and heat. All those produced in the area of the tissue damage. And this could be in the skin, but it could be deep in the internal structures, particularly around bone, which is well invested with pain fibers. And this describes many of those effects, including those neuroactive peptides, substance P and CGRP, which are released peripherally, but also the substance P is released at the synapse in the central nervous system. These are multiple activators of the peripheral receptor. And then we see the inflammatory factors that produce heat, redness, and swelling. just as an infection might. These agents that are activated or sensitized nociceptors are identified here. The source of each of those is identified over here. And for some of them, there is an enzyme involved in their synthesis. Of particular interest is that the prostaglandins are dependent on cyclooxygenase for their generation. And aspirin and other non-steroidal anti-inflammatory agents, such as ibuprofen and umethicin, inhibit this enzyme, and thus they inhibit the synthesis and release of prostaglandins from damaged cells, and that reduces pain. They do not, the aspirin does not block the action of prostaglandins. So if you get the aspirin in early, it'll have a benefit. If the prostaglandins have already been released, then you don't get as much benefit. The pathway that these painful inputs are traversing is shown here with the peripheral nerve, dorsal root ganglion coming into the dorsal horn, synapsing in the dorsal horn on a neuron that travels across the midline, that's a secondary neuron, and comes to begin the spinal thalamic tract, also known as the anterior lateral system because it's anterior and lateral, and will travel up to the brain. It'll actually travel up to the thalamus, synapse in the thalamus, and then the tertiary neuron will go on and synapse in the somatosensory cortex. Coming off of that main trunk of the spinal thalamic tract are branches to the brainstem, both in the medulla and in the midbrain, seen here. Those are of great interest because those pathways result in alertness, and pain has a very dramatic effect on alerting and pain and forcing attention, and into the periaqueductal gray, but it also activates systems that travel downstream into the spinal cord to modulate that sensory pathway, to actually help to reduce input and modulate the amount of awareness of pain. And the same thing happens in periaqueductal gray. It sends a descending pathway that tends to modulate the activity of the pain pathway. As it goes all the way down to the spinal cord, and we'll see that that modifies, and we'll see that how that modifies some of the activity of the ascending pathway. There are also branches going off to other parts of the brain besides the somatosensory cortex, and that includes the amygdala and the insular cortex and the cingulate cortex. These regions, the amygdala, insular cortex, and cingulate cortex, are particularly important in the emotional reaction to pain. I'll draw your attention to two features of this pathway at the spinal level, and that is the fibers that come into the spinal cord. Synapse, as we said, on the same side that they come in, and then they cross to the other side, and they cross to the other side through a pathway known as the anterior white commissure. They then occupy a position and they join the spinal thalamic tract in this anterior lateral position. The important consequence of this is that the fibers at the anterior white commissure contain only information from a segment or two that contain pain information. So damage to the anterior white commissure at a particular spinal level will influence pain perception only at the level of those spinal segments in which it is damaged. So you might have a loss of pain and temperature only at a couple of segments of the spinal cord. Whereas damage to the spinal thalamic tract, which now carries information from all of the fibers that had entered the cord below this level, includes all of the fibers from below. And as a result, there might be a loss of pain and temperature on the other side of the body when there's damage to the spinal thalamic tract, and it might extend all the way down to the lowest level of the spinal cord. Whereas fibers above that level might be uninfluenced. So as a result, you'll have a spinal level
for pain and temperature near this level, but it might be 1 or 2 segments above because of some dispersion of fibers at this level.
When pain fibers come into the central nervous system, they first synapse in the dorsal horn, and they're shown here in these red blobs, some of the locations that they synapse in. Large numbers of them synapse in the most exterior portion of the dorsal horn. These are various rexid lamina that are identified here, 1 through 5, and there are others all the way through 10. But most of them synapse in the most superficial portions of the dorsal horn, posterior marginal nucleus, substantia gelatinosa. Some will travel through interneurons down to those lower levels, and eventually synapse on these neurons that we see in the dorsal horn, and those neurons will cross to the other side, and they will become the lateral spinal thalamic tract. But recognize that some will project up to the reticular formation, some will project up to the thalamic nuclei.
The viscera are also innervated by C fibers for pain. Some of these C fibers run in autonomic trunks and converge in the dorsal horn with pain fibers from the skin. As a result, tissue damage to various viscera, various organs, may be perceived, that is referred to, as originating at different regions of the skin. For instance, angina might be identified as coming from the left arm. Kidney stones might be, in fact, identified as coming from the back.
Aortic aneurysm, renal and pancreatic pain may radiate to the back and be misperceived as that's the source of tissue damage. Similarly, renal colic may radiate to the groin. Diaphragm pain may feel like coming from the shoulder rather than from the diaphragm, and gallbladder pain may appear to be coming from the scapula, even though there is no damage at the those referred pain regions are recognized by this kind of map that shows, as you can see, the region over the shoulder and the neck might be painful, even though the damage is to the lung or the diaphragm. There are a variety of mechanisms of controlling pain, and some of those are identified here in 2 different ways, both as segmental and suprasegmental. Here we see the mechanism involved in segmental control of pain, and is one you would all be familiar with, and that is when you have a mosquito bite, you rub that skin right over the mosquito bite, and somehow that diminishes the pain. Here is the mechanism that appears to be responsible for that. The C fiber carries the pain information from that mosquito bite, carries it to an interneuron, and activates that interneuron. The interneuron then activates a projection neuron that will travel across to the other side and form the lateral spinal thalamic tract. On the other hand, that's the normal pain perception. In that same peripheral nerve are nerve fibers, alpha fibers, large sensory fibers that detect touch on the skin. They would normally project into the central nervous system and send information that will travel up the spinal cord and provide information about touch. Well, it turns out that these alpha fibers will activate interneurons in the spinal cord, in the ventral horn, in the dorsal horn, excuse me, and that interneuron is an inhibitory interneuron. And in fact, it inhibits the pain pathway. You see right here, both presynaptically and postsynaptically. That is a release of a neurotransmitter that's inhibitory. It's either glycine or GABA. So that when pain is coming here, if you simultaneously activate the touch receptor, it will inhibit the pain pathway and diminish the pain sensation. That's the effect of rubbing the skin.
This segmental control of pain was originally described as the gate control theory of pain because activation of A fibers controlled transmission through pain fibers, that is through the C fibers. Notice that it has come to be recognized that it utilizes an encephalinergic receiving neuron, and that enkephalin is an endogenous opiate, a site at which morphine might be effective.
At the suprasegmental level is another system, and we referred before to upgoing pathways that stop at the periaqueductal gray and at the reticular formation. Well, in the periaqueductal gray are a number of neurons that are encephalinergic neurons. Encephalinergic neurons release a neurotransmitter that is an endogenous opiate. That is, just as the opiate poppy can produce opium, the body has produced substances that have a similar pharmacological structure, chemical structure, and it tends to be an inhibitory setting, and it changes the excitability of this pathway. And this pathway can modulate the activity by sending their long pathways down for a variety of locations, both in the midbrain and lower brainstem in the medulla, that end up on those inhibitory interneurons, and as a result, the brain itself can modulate the excitability of the afferent pathway. And much of this input comes from the raphe nuclei in the midline of the brainstem. Those endogenous pathways are seen briefly here, and that is coming down from the periaqueductal gray to the raphe nuclei, and also from the nucleus paragigantocellularis down to the dorsal gray to control afferent pain information. A summary of these pathways is shown here, where you see the primary sensory input coming in and releasing glutamate or substance P, activating interneurons, and eventually the spinal thalamic tract, which goes up to the thalamus, but it also sends branches up to the reticular formation and the periaqueductal gray. The direct sensory pathway is going to go up to the cortex to let the brain know where the stimulus is and how strong it is, and this information goes to the periaqueductal gray, which has the capability of sending pathway down to the spinal cord, into neurons in the spinal cord that have encephalinergic synapses that can modulate this pathway. Coming from the periaqueductal gray inputs to the deeper brainstem, that is medulla, can also release neurotransmitters on these projection neurons in the spinal thalamic tract that can moderate the amount of pain information that's going up through that pathway. This periaqueductal gray, as well as the cortex, is very much influenced by the amygdala and the hypothalamus to modulate overall projection of pain information within this sensory pathway. As we indicated, the opioid receptors are found both in the dorsal horn and in the periaqueductal gray. And these are usually on interneurons at these sites, and they're considered endogenous opioids. As much as morphine can be used to reduce pain, these endogenous opioids also reduce pain. Those kind of receptors, opioid receptors, are also located at other regions. And they are one of the side effects as a result. The side effects of opiates used as painkillers may influence receptors present in muscles of the bowel or the anal sphincter and result in constipation, a very common side effect of the action of opiates. Other receptors in the nucleus of the solitary tract in the brainstem account for respiratory depression and cardiovascular changes, which certainly contribute to the death of people with overdoses of opiates. So we see that there are many ways of controlling pain, and that might be through pharmaceutical effects or by alternative behaviors, and the pain that might be reduced by the stinging of a nettle. We see here the objectives that we've covered. If you have any questions, don't hesitate to contact me. Thank you.